So we're going to talk about Medicare for All, and we're going to talk both about sort of the concepts and why, and I'll bet you all know some of it, but I'm going to talk about it in very specific ways so that you can, my goal of that part of the discussion is to arm you when you want to have this discussion with other people. And we'll do that for the first half or so of my time, and then the second half of my time we'll sort of deconstruct the way that I spoke about it. So I'll sort of be in character speaking about it the first half, and then the second half will be in and out of character. I'll show you sort of why I chose the specific words, because it's one thing to talk to our friends and rally the base, but it's another thing to try to realize how much we all have in common. So that's sort of the run of show of what I'm planning on talking about with you. I'm a family physician. I practiced for 20 years in Chicago, delivering babies and taking care of older folks and all the stuff in between. I'm really proud of that. I still do that. I still see patients on a regular basis volunteering in a safety net clinic in St. Louis at least once a week. I love seeing patients. It's sort of my core. And then I got recruited to work at Express Scripts. The reason I moved from Chicago to St. Louis was to be chief medical officer at Express Scripts, a pharmacy benefit management company. So just about as far into the insurance side of the equation as you can want to get. So I learned a lot about it from the inside. And one thing I learned is that if you want to make a change in the way things work, you really have to have a business case. It's one thing to have an idea. It's very easy to confuse a goal with a plan. And you have to have a compelling business case if you want to get more support. So you'll see that filtered through most of what I have to say. So I retired from that in 2010, and in 2012 or so, we organized the Missouri chapter of Physicians for a National Health Program. So we're a nonprofit. I'm a volunteer. We're pretty much all volunteers. We're 501c3, nonpartisan. We don't support any particular politician or party. It's just policies, basically. We're open to non-physicians. A lot of our members are actually not physicians, and we'll talk more about that a little later. So here's sort of the problem. I'll show you really one example of the problem. We'll mainly talk about solutions, but here's the problem. So if you turned 50 in 1980 and you were wealthy, you probably had another 36 years to live. If you turned 50 30 years later, more recently, so in 2010, your remaining life expectancy actually went up. So that's, hooray, life expectancy went up. That's for the wealthiest Americans. And no surprise, the least wealthy Americans in 1980 had a shorter life expectancy than the wealthiest. You knew that. But here's the sort of the striking thing. Since then, their life expectancy has gone down. The poorest and the wealthiest has gone up. And I think of that as the death gap. The difference, turning 50 in 1980 versus 2010, the difference was 4 years. And now, most recently, the difference is 13 years. So we have this gap of life expectancy based on your income that's getting worse, and that's very disturbing. And we have a solution to this problem. There's a million manifestations of the problem, but this, I think, is one nice, clear one. So it turns out Americans are very concerned about this. If you ask Americans, which are you more afraid of, getting sick or paying for it when you get sick? We're actually more afraid of paying for the illness than actually getting ill. We're more afraid of paying for a serious illness than we are of actually getting ill. If you've not been sick and not had a major financial impact from getting sick, you don't really recognize that. But if you have been sick and had a major illness, it turns out, and had a major expense, you're even more concerned about this. So once you've experienced it, you realize this is a big deal. So we're going to talk about building a solution based upon Medicare. We're not talking about Medicaid for all, we're not talking about Blue Cross for all, we're not talking about Medicare Advantage for all. Why Medicare? What's so great about Medicare? Why build it on Medicare? So here's the first Medicare member, Harry Truman. He became a member 1 year after the law was passed, so it was actually not hard to do. Medicare rescues seniors from poverty and extends life. It's a hugely successful program, and you all know some about it, but I'm going to emphasize 3 specific things about Medicare that you may know, but you may not know, and may not realize the importance of. The first is it puts you in control of your healthcare decisions. Second thing is it eliminates most of the waste in the healthcare system. We'll explain that. And then lastly, it actually extends our life expectancies. So we'll walk through this a little bit. First, it means you're in control. And for me to really explain this, I need to introduce you to someone, our mother-in-law. Hey, Mom. I just like seeing my mother-in-law 10 feet tall. She's actually, I'm one of these lucky people. I actually really like my mother-in-law. So there she is. I have her permission to tell you this story. Ma is in her mid-80s. She lives in Florida. She has a rare genetic disease in her heart. She has Hogan. This is one of these genetic things that turns out not to really manifest until maybe your mid-70s typically, and it eventually is fatal. And she had it, right? And it turns out that this is so uncommon that there's only actually 3 places in the country that focus on treating it. And one of those 3 places is in St. Louis. There isn't one in Florida. One is in St. Louis. So we flew my mother-in-law from Florida to St. Louis. We didn't have to call Mother May. We didn't have to get permission. We didn't need to call the insurance company. We didn't have to do that. We flew her here. She was treated at arguably one of the best places in the world for this. And she has Medicare and a supplement, so she didn't have to pay a penny. She didn't pay a penny. She's paid her premium, she's paid her taxes for her whole life, but she didn't, and she has a supplement, but she didn't have to pay a penny. So my mother-in-law has Medicare. She could decide where she wants to go for her health care anywhere in the country, and she didn't have to pay, other than what she has been paying. My wife, I have her permission too to tell you this story. My wife may have this problem. She has some suggestive symptoms, but she's been tested. We don't know. But let's say my wife has this problem. And let's say the best place wasn't St. Louis, but was Pittsburgh, let's just say. Well, I pay $2,000 a month premiums. That's what I pay, $2,000 a month for a premium, $24,000 a year. That comes with a $6,000 deductible per person. $12,000 per family. I'm seeing some heads nodding. So if Cindy, my wife, needed to go to Pittsburgh, I would have still paid my $24,000 premium, maybe some of that deductible too, and Pittsburgh would have been out of network. So the roughly $100,000 bill that my mother-in-law got, that'd be on me. Well, most of us can't actually afford a $100,000 medical bill, so we make life-threatening decisions and maybe die. So my mother-in-law has Medicare and a supplement. She can go anywhere. I don't, but a lot of you don't, and you can't. So that's one of the things. And if you talk about messing up her Medicare, she gets very unhappy. So Medicare, so why Medicare? I mean, we know that there are doctors who won't take Medicare, so why are we building a system on Medicare? Why do that? Well, so let's look at the numbers. Turns out that there's nearly 700,000 physicians in practice in 2013, seeing patients, nearly 700,000, and there are nearly 10,000 who won't take Medicare patients. So if someone says, well, there's thousands of doctors who won't accept Medicare, they're telling you the truth, but the rebuttal of that is, well, yeah, but there's hundreds of thousands who will, so that's more than 98%. I mean, that's a pretty good number. So in other words, with Medicare, you're in control. You're in control, and I think that's incredibly important. Who else should be in control? Another thing is it stops wasting our money. So raise your hand if you like wasting money. Every once in a while somebody raises their hand. Not in Oklahoma. So here's overhead for the larger insurance companies, essentially medical loss ratio from 100%. For Aetna and WellPoint and United and such. And you can see their overhead is in the 15 to 20% range. And then here's the overhead for Medicare A and B, traditional Medicare, 2.2%. And that overhead supposedly includes the brick and mortar of the buildings and the IRS staff that collect the fees and all. It's all in. So it's hard to make that up. That's a huge just overhead. They pay for marketing, right? They pay for ads on the TV. They pay for underwriting sometimes. They pay for all kinds of crazy things that Medicare doesn't have to pay for because it's simpler. So here's my wonkiest part. It also makes us healthier. And I apologize if this is wonky, but I know you can do this. So let me explain this to you. Here's our mortality rate, and I think of it as life expectancy, but it's mortality rate, stratified by age, as compared to 17 other peer nations. Denmark, Finland, France, Germany, I can read the list to you. All of my slides that have numbers on them, there's a footnote here. It's too small for you to read, but if you have a question, I can tell you exactly the source that I have for it. And they're all sort of public domain, peer-reviewed good objective, not the Journal of Ed. They're really good sources, and I can tell you any specific one. So here's 7-year-old Americans' mortality rate compared to 7-year-olds all over the rest of the world. Here's me. Here's a 64-year-old American's mortality rate or life expectancy compared to mortality rate for 64-year-olds in 17 other countries. And here's my mother-in-law in her mid-80s compared to mother-in-laws elsewhere in the world. So you knew the first part of this, right? You knew that our life expectancy here is 2 or 3 years shorter than it is elsewhere in the world. And so there we are, despite paying double almost every other modern nation. The worst of all those nations. And then something amazing happens when we turn 65. Did you know that? Did you know that? Did you know that once you turn 65, American life expectancies, or mortality rate, literally, become some of the best in the world? Isn't that remarkable? So that means to me that we must have many of the world's best hospitals and doctors and nurses. You couldn't do that if you didn't. And that means that Medicare is something we should be just hugely proud of. So let's talk about how healthcare is organized around the world, because I think of it as 3 sort of high-level summaries. So let's talk about that and give a concept of where Medicare fits into this. So the first example is over here to your left, and this is a national health service. This is where you pay your taxes. This is where the government then builds the buildings, owns the brick and mortar, hires the doctors, fires the doctors and nurses and all that. This is socialized medicine, right? Socialism, as I understand it, y'all may know more than I do about this, but socialism, as I understand it, is when the government owns the means of production. So this is socialized medicine. It exists, it's real. It's how the VA does healthcare. It's how Great Britain, Cuba, and a few other countries. And frankly, the outcomes of this, in many settings, are some of the best in the world. Some of the best, so I'm not in any way disparaging this. But this is literally socialized medicine, and it is not what I'm here to talk about. It's not what either bill in the House or the Senate are about. It exists. It's not what I'm here to talk about, though. But on the other side of the equation, to your far right, there's the way we organize it around here. And I'm not going to belabor it, just to say that there's gaps and problems. So these, in my mind, are 2 extreme ways of setting up healthcare finance. I don't say extreme in a pejorative way, just extreme in the sense that that is as far into healthcare finance, healthcare, as a government can go. There is no further in, and so that's extreme. Good or bad, that's extreme. This is also extreme, and I call this extreme, again, not good or bad. Maybe we've figured out the best way, but it's extreme because there is no one else in the world that's chosen this model. When you're the only one doing something a certain way, maybe you're best at it, but you're the only one doing it that way, it's extreme. Good or bad, it's extreme. And I frame it in these 2 extremes because in my mind, there's a really conservative model smack dab in the middle here, which only deals with the insurance side. Really, when you're talking Medicare for all, you're only talking about insurance. It can create a cascade of other things that we need, but we're only talking about insurance at this point. So this is publicly funded, right, tax funded, but privately delivered with a current arrangement of doctors in solo practice or working in groups or owning groups or working for a hospital or working in the Indian Health Service or working in the VA. A wide array of private practice delivery models, publicly funded, privately delivered, and that is how they do it in Canada. Canada invented the word Medicare, we took it from them, and that is how Medicare works here in a few other countries. So I think of this as a good use of the market in healthcare. So think about this. So today, as a physician, I am competing against other physicians in a market basis, not for you. I'm competing against other physicians for the most lucrative insurance contract I can get. I spend my time competing for the best insurance contract I can get. Because think about it, I think the average primary care doctor might see about 4,000 patients visits in a year. And if I can get $5 more per visit, spend a couple hours negotiating, get $5 more per visit from a better insurance company, and I'm sorry, that means I have to drop your insurance company, you can't see me anymore. But if I can get $5 more for every visit, that's $20,000 more a year for no extra work that I can then keep getting. So that's the way the market is working today for physicians. It's making me compete with other physicians to get the best insurance contract I can get. And if one or two patients come or go, that doesn't affect me materially, financially. The insurance contract does. And that makes me sick. That makes you sick. That makes me have to spend my time assessing what you're worth to me economically before I let you into my practice. So I don't know how the prices are in Oklahoma, but in St. Louis, if I see a Medicaid patient, if I see you and you have Medicaid, I'm going to get about $30. If I see you and you have Medicare, I'm going to get about $100. And if I see you and if I see you and you have Blue Cross, I'll get about $130. So I need to see you all the time, and I don't know how often I can stand to let you in my practice. Sorry, I don't want to do that. Everybody should be worth the same economically to a physician. You should come see me if you want to, and you should leave me if you want to, and there shouldn't be somebody else telling you what to do about that. And that, to me, is a really good use of the market for medicine. Make me compete to have you want to see me, rather than make me compete for an insurance contract. So there's a bill in the House, and there's a bill in the Senate. They're very similar. If you want, we could talk about the differences, which I think are enormously important, but we'll emphasize the similarities for right now, and we'll talk mainly about the bill in the House. So the bill in the House, you should read it. It's only 30 pages, double-spaced, big font, easy to read. Google it, it comes right up. It'll become more complicated as it progresses through the legislature, but read it now, and it's got a good strategic answer to most things on your mind. And it says basically two things. It says improve Medicare and expand Medicare. So you've heard the word improved Medicare for all. What does that mean? What's the improved? There's really two main things to improve. First is there are important things that seniors need, that we all need, that are not covered by Medicare today. Medicare doesn't cover dentistry, it doesn't cover eyeglasses, it doesn't cover hearing aids. There's a list of about 15 or 20 things that Medicare should frankly cover that it doesn't. So, and we want Americans to have those things, so improve Medicare. Put these better benefits into Medicare. And Medicare has as a second major flaw, there's financial barriers. So if you have Medicare, you probably have a large deductible and co-pays and other problems. And that's why most seniors who can afford to buy a supplement or a wrap. So fix that, get rid of the co-pays and deductibles. And then there's no market for the supplements and stuff. So that's what we mean by improve Medicare. We mean fix the benefits, glasses and dentists, and get rid of the co-pays and deductibles. And then give it to everybody. Give it to Congress, give it to the president, give it to the mayor, give it to teachers, give it to students, give it to kids, give it to people currently on Medicaid, give it to everybody. And that's not just to be nice. Giving it to everybody does a few really important things. First, that's the only way to get that waste out. You saw the overhead. You saw those big red bars of 18% overhead, and you saw that little tiny bar of 2% overhead. Well, let's stop that big red bar and get to the green bar. That's the only way to get rid of most of the waste is by putting everybody into this program. Secondly, of course, it makes a large, stable risk pool, so small employers don't have to go crazy with, I hired somebody that now they got hemophilia, and now my healthcare costs are going to go up by $1 million next year. That's really hard for small employers to manage this fluctuating risk because they've got 25 employees or whatever. Everybody's in the program. The nation's health is what determines your expenses, not whether you hired somebody who now has Hep C or something. So very stable. And lastly, of course, this makes it resistant to legislators messing with it. So it's really important for that business. So Medicare for all is really simple. Let me make it even more clear for you if I could. Here's us, right? There's all the Americans, and here's all the stuff we want. We want doctors and pharmacists and such. And between us is, guess what, the money. And the money today is managed by a lot of different groups. So we pay our taxes to the U.S. government, and the U.S. government pays for Medicare and for part of Medicaid and for the military and the post office and on and on. So they are one of the payers, right? So is the state. So if I should have put Oklahoma's map, sorry. So is the city. That's St. Louis, the city. So are schools and businesses and insurance companies. So these are payers. So our system today has literally thousands of payers of this sort. And so it's called a multi-payer system. It's really expensive. You just look at all those things you have to maintain, and they're all typically doing the same thing, just not scaling it up. So it's really expensive, and there's these big gaps because it doesn't cover everybody. So that's a multi-payer model. That's how we do it. You could replace all these payers with guess what? One payer. So now you know what a single payer is. That's what we meant by that. And the most prudent way to do that is by improving Medicare and giving that to everybody. So that's what that means. Turns out this makes really good economic sense. There are literally 25 studies that have looked at whether or not we can afford Medicare for all, and they've said we either break even or we come out ahead. There are two that come to a somewhat different conclusion, and I'll explain what I think as important flaws with those two in a moment. And it's really important for you to understand the flaws that I'm going to explain, because I promise you in the next 2 years, there's going to be another study coming out, and it's going to, right before the next general election, and it's going to say, we can't possibly afford it. So you need to know what the two flaws are that you've seen in the past, because they'll probably be the same things the next time. So first, let's walk through one of these studies, and this is from Gerald Friedman. He was the head of the Department of Economics in Massachusetts when he did this. And he said, of course there are new costs, but there are new savings, and the savings are bigger than the costs. So what are the costs? Got to pay more for Medicaid patients, as we were just alluding to. You have to pay something for people who don't have insurance today, and then everybody's going to start doing things, right? They'll go to the dentist, they'll do stuff we frankly want Americans to be able to go do. So, one of the major flaws is that one of the studies literally stopped here. The one that was in the Wall Street Journal and USA Today right before the last general election that said, well, look at Bernie Sanders' plan, it costs crazy amounts. It stopped here. It literally stopped here and said, there's these new costs, we can't possibly afford that. Well, that's not fair. That's not genuine. You have to look at the new savings. You can still disagree about the philosophy and the politics and the strategy. That's fine. But for crying out loud, you have to give some recognition to the idea that there's some savings. Well, what are those savings? Well, it would be cheaper to administer one program, right, instead of the dozens. We would save money on health insurance administration, because a lot of that work would frankly disappear. The average physician today has $85,000 in staff, $85,000 in staff who do nothing but manage the insurance industry for them. Do nothing today but manage the insurance industry for them. The average hospital, there are more people in the United States working in billings and accounts receivable for hospitals than there are beds in hospitals in the United States. So in the country on a whole, some more, some less, but on a whole, the average hospital could put somebody full-time from billings at the foot of every bed and have an entire department left over. Toronto General has 3 people in billings, 3, and one of those 3 works on Americans who came over the border. So we have buildings full of staff that do nothing but manage the insurance industry, and they have 3 people. So there's a savings here. And then lastly, of course, we have to let Medicare negotiate the prices for drugs and devices. So I mentioned that we would not need physicians to have $85,000 of staff. I mentioned that we would go from buildings of insurance people for hospitals to 3, perhaps. Well, what does that mean for jobs? Because guess what? We all care about this a lot. So let's look at this. And first, I will show you some disturbing numbers about what it would do for jobs. But then I'll show you some context and some mitigation strategies, and I think it's an issue we can cope with. But what does it mean for jobs? Well, first, how many jobs are we talking about? So, first of all, we're talking about pretty much everybody that works for the insurance industry today. Pretty much everybody, if we follow this particular model. Secondly, there's about 2.6 million people working on physician offices and hospitals, and you would probably need still half of those for certain things, but roughly half of them. So in other words, 1.7 million jobs. Now, these jobs some of them are really professional jobs with long-term standing, and people stay there. But most of these jobs actually are sort of data entry and call center and stuff that has a 25% annual turnover. That's an important number. These jobs in general have a 25% annual turnover. So that means no matter what you do today, more than half of these people will not be in that job in 2 years anyway. More than half already won't be, so it's 1.7 million, worst case, but more than half of them, from the time you pass the law in the House Bill 2 years, in the Senate Bill 5 years, or 4 years, a lot of them would already, just by natural attrition, not be in those jobs. So what do you do about it? Well, the first thing, which nobody wants but is important to have, is something based on one of the good parts of the GI Bill from World War II, which is both bills have guarantee of your income. So if your job is displaced by this, both bills say, and it's built into the economics, both bills say that for 2 to 5 years, depending on the bill, up to $100,000 a year, your income is preserved if your job gets disrupted. Nobody wants that. Nobody wants that. You don't want income guarantee. You want a good job with meaning. It's good to have this as a safety net, in case you're in this trap. So there's that. It's thought out, included in economic model. Second of all, this would create a business case for doing all kinds of clinical things that we don't do today, that we should do today, but there's no business case today. And some of these jobs, some of the folks we're talking about would move into these jobs. Not necessarily clinicians, right? We've discovered that if you take a senior who's living by themselves and is very isolated and lonely, doesn't have a support network, if you just send someone to their house on a regular basis, you can actually reduce their hospitalizations. So you can make a business case, and this is one example, there's many of these examples, you can make a business case for not just nurses and doctors, but for lots of people to start doing things that really add meaning to lives and pay for itself, if you capture the whole system. So the clinical workforce would need to be improved and expanded, and that's one big place where these jobs would go. Then the second thing, of course, is this would be very stimulative to the economy, right? Lots of businesses that would want to grow but can't grow today because their cost of healthcare is so overwhelming that they're paralyzed. This would disburden them. This would free them up. So we've seen this around the world that this actually is very good for business. More importantly, and of course, don't forget income guarantee if you still need that. More importantly, perhaps, put it in this context, how many people change jobs today? So remember, we're talking 1.7 million, worst case, probably half that if you think about the turnover issue, and then mitigated, probably way less than half that. So how many people are we talking about today? It turns out that today, and for the last 17 years, probably longer, roughly 20 to 30 million Americans quit their job every year today. 20 to 30 million Americans quit their job every year today. Another 20 or so million are fired every year today. And then another 5 or 10 million have something else. So today, roughly 60 million people every year, 60 million people every year change jobs. Compare that to the unmitigated 1.7 million. So we have strategies to mitigate it. We have a safety net below it, and put in the broader context of employment, I think it's a deal. So the last one of these sorts of arguments I want to make is to compare us to Canada. And the reason I want to compare us to Canada is because this model would be very similar to the Canadian model, and whenever you start talking about Canada, the first thing people say is, Canada, it's nothing like the United States, right? It's, it's less diverse, it's bigger, it's this, it's that. And why would you even talk about a Canadian system? And the reason is, that's not true. So if you look back to before 1971, the results of our healthcare system were almost the same as the results of the Canadian healthcare system. We were spending the same amount as a percentage of GDP on the same cost trend curves, and our life expectancies were a few months apart. And then we had a policy change. In 1973, President Nixon signed into law the HMO Act to reduce the cost of healthcare. So we started the managed care industry, and in 1971, that happens to be the year that Canada fully implemented their Medicare for All program, their national health insurance. So we were the same, and then we created managed care, and they implemented Medicare for All. So what does the data look like? We have all this data from however long that's been. You've seen this, right? This is the relentless climb of our healthcare costs as a percentage of GDP, now getting around 19% or something. You've seen that. Here's the HMO industry getting created, really not making a noticeable impact. So you've seen that. Here's Canada's data. We were the same. Then we had a policy change. They went Medicare for All, we went managed care, and now they spend half of what we spend. Here's our life expectancy difference. This goes to 1979. I'm sorry, there isn't comparative data from much further back than that. Here's 1979. They were living already 1 year longer than we were, and now they're living 3 years longer than we were. They now live 3 years. We were the same. Now there's this big red zone in my line. So it's time to stop this experiment. We were the same. Now They spend half and live significantly longer than we do. It's time to stop this. So, there's been a shift in the country. So if you ask Americans, is it the responsibility of the federal government to ensure that everybody has health care? This isn't Medicare for all. This is saying, is it the responsibility of the federal government to ensure that everybody has health care? This survey has been repeated several times. In 2013, right, before full implementation of the ACA, 2013, a minority of Americans, less than half of Americans said, yes, it's the federal government's job. And then the ACA came live, and by just about a year or two later, a slim majority. And then we had this election, as you probably, did you notice the general election in 2000? Yeah. So now actually 60% of Americans, it's not Medicare for all, I'll show you that in a moment, 60% of Americans say it's the federal government's responsibility to make sure that everybody in the country has access to health care. Most Americans agree with that, and they didn't 5 years ago. So this is changing. It's changing. And if you ask parties, break it down by parties, do you favor or oppose expanding Medicare? So this is the Medicare for all to everybody in the country. And this is 2017. Most Democrats, 3/4 of Democrats, say yes, I support Medicare for all. If you ask Republicans, guess what? Not most. Really surprisingly close to most. Only a third of Republicans actually oppose this. And so there's the bill in the House that you are familiar with, H.R. 676. It was introduced in 2003. That's the bill we just walked through. And it was originally introduced by John Conyers, and now Keith Ellison is the sponsor. And when it was introduced in 2003, it had 38 co-sponsors, and it gradually grew in popularity to 93 co-sponsors. And then the ACA was enacted, and a lot of the people that were supporting the bill kind of migrated over towards, protect and expand or whatever the ACA, and so it kind of fell off. And then we had, once again, this general election, and now 122. 122. That's a majority, of the Democrats. We have yet to get a Republican co-sponsor, but I defy you to tell me what I said that was partisan. We have yet to get a Republican co-sponsor, but I'm hopeful that we will. But a majority of the Democrats, the bill in the House, the Senate has 17 co-sponsors, and that's thought to include everybody who's thinking of running for president on the Democratic side in 2020. So think about that. This has gone from a marginal issue of fringe folks, less than half, to table stakes to run for the United States presidency. Huge. It hasn't passed yet, but all these intermediate endpoints, it's huge. Before I go on, I would like to know who you are, so we can keep you informed on things. And I've got actually a clipboard. Let me get it for you. We have little handouts. If you didn't get the handout, let me know. We have more of them. But I do have this clipboard that I'd like to pass around and ask you all to give us your contact information. So, if you want to hear more when we're coming back to Oklahoma, if you're lucky to start a chapter here, so we can collaborate better with DSA and others. If you want to stay in touch, give us your contact information. So, you don't have to be a physician. We have Facebook pages and all that. The information like that.